When a light bulb flickers in your house, I mean, you usually just assume the bulb itself is dying, right?
Yeah, you don't think about the wall.
Exactly. You don't immediately think the hidden wiring running through the walls of your house is just like slowly corroding from the inside out. But right now, inside millions of people, this vast invisible wiring system is breaking down. So, welcome to today's deep dive. We are mapping the human body's peripheral nervous system.
Which is a fascinating system, by the
Oh,
way.
it really is. And we're pulling from a huge stack of clinical data, medical history, and pathophysiology to find out exactly what happens when those wires short circuit.
And we really have to start with a massive paradigm shift here. Because when people hear the term peripheral neuropathy, they almost always assume it's a specific disease.
Yeah.
You know, much like malaria or cystic fibrosis.
Right.
But it isn't. It's actually a syndrome.
Okay, let's unpack this. Because saying you have neuropathy is kind of like telling a mechanic your car makes a funny noise.
That is a perfect way to put it.
Right, like it tells you the system is malfunctioning, but it tells you absolutely nothing about the underlying cause. I mean, the check engine light is on, but the reasons could range from a dead battery to a blown transmission.
Exactly. The word itself, it comes from Greek. So neuron meaning nerve and pathos meaning suffering. Literally, nerve suffering.
Nerve suffering,
Yeah.
wow.
And to understand how we even began to differentiate this suffering from, other neurological issues, we actually have to look back to 19th century Paris.
Oh, Jean-Martin Charcot, right.
Yes, working at the famous Salpêtrière Hospital. He had thousands of patients with various forms of paralysis and pain. And at the time, if someone had, say, a weak leg, doctors just couldn't tell if the problem was in the brain, the spinal cord, or the leg itself.
Because there were no MRIs.
Right, no imaging at all.
So Charcot basically had to map the body's electrical grid by hand, which is just wild to think about. He systematically documented which physical nerve pathways produced which specific symptoms when they were damaged. And that finally allowed doctors to distinguish peripheral nerve disorders from central nervous system disorders.
Which brings us to the geography of this grid. So the brain and the spinal cord, they form the central nervous system. You can think of them as the command center and the main fiber optic trunk line.
Okay.
Everything downstream from that. The vast branching network reaching out to your fingertips, your toes, your skin, and even your internal organs. That is the peripheral system.
But before we can understand how this peripheral system breaks down, we really need to understand how it's built in the first place. So if we stick to the wiring analogy, a peripheral nerve isn't just a single solid cable, is it?
No, not at all. It's a bundle of insulated wires. So the core wire is called an axon, and it is a long, highly specialized extension of a single nerve cell.
Just one cell.
Just one. And to conduct electrical signals efficiently, many of these axons are wrapped in a fatty insulating sheath called myelin. That myelin is produced by support structures called Schwann cells. They basically wrap themselves around the axon like a jelly roll.
Like a jelly roll. Okay. And these axons are divided into three incredibly distinct functional categories, right? Like motor fibers carry the action signals from the spine out to the muscles.
Yeah.
So if those wires fray, you experience weakness, muscle wasting, or you lose your reflexes entirely.
Exactly. Then you have the autonomic fibers, which act as the subconscious background operating system.
Stuff we don't think about.
Right. They control your heart rate, your digestion, your sweating.
And then there's the third category, which is sensory fibers. These carry environmental data from the skin and joints back to the spinal cord. But wait, so if I touch a hot stove versus feeling a vibration on my phone, are those signals traveling on the exact same type of wire?
They are absolutely not. In neurology, the physical size of a sensory fiber dictates exactly what kind of information it transmits.
Really? Just the size?
Mostly the size and the insulation. So we have large, thickly myelinated fibers called A beta fibers. Because they have thick insulation, the electrical signal travels incredibly fast.
Yeah.
These handle complex data like light, touch, vibration, and proprioception, which is your brain's awareness of where your limbs are in space.
But the wires that carry pain and temperature signals are built completely differently.
Right, they're much smaller. So you have A delta fibers, which have very thin myelin insulation. They carry the sharp, immediate pain you feel when you cut yourself with a knife,
Yeah.
as well as the sensation of cold.
Ouch. Okay.
And finally, you have the C fibers. These are tiny, and they have no myelin insulation at all.
None.
None. The signal moves really slowly, and they carry sensations of warmth, itch, and that deep burning pain.
Wow. So when these different wires break, they don't just quietly turn off. Like, if a massive A beta fiber fails, you might lose your sense of touch, that classic numbness we think of. But if a tiny, unmyelinated C fiber gets damaged, it frays and sparks, which explains why a patient with nerve damage feels agonizing burning or like electric shock pain. The broken wire is constantly misfiring, sending false alarm signal to the brain.
Exactly. And there are two fundamentally different ways these wires can fail. The first mechanism is axonal degeneration. This is where the core wire itself slowly dies.
Oh, wow.
Yeah, because the cell body lives near the spinal cord and has to ship proteins and nutrients all the way down the axon to the tip, these cells are under immense metabolic strain.
Well, yeah, because some of these single cells are over a meter long. Like the nerve running from your lower spine down to your big toe is a single continuous cellular structure. That is crazy.
It is. Imagine running a supply chain down a 1-meter microscopic tube.
This sounds impossible.
If the body is under toxic or metabolic stress, that supply chain breaks down. So the furthest outposts starve first. This is why axonal degeneration almost always begins at the furthest tips of the nerves and works its way backward. We call it dying back degeneration.
And clinically, this creates what is called a stocking glove distribution. So the numbness or pain starts in the toes, slowly creeps up the feet and calves, and it only begins to affect the fingertips years later. Basically, once the disease has progressed so far that the nerves reaching the hands are now the longest ones left intact.
Exactly. Now, if a nerve is physically severed by trauma like a deep cut, the portion disconnected from the cell body dies rapidly in a biological process called Wallerian degeneration.
Okay, so that's the trauma version.
Right. But in systemic diseases, we see that slow dying back starvation.
Got it.
The second failure mode is demyelination. So the core axon stays intact, but the immune system or a toxin strips away that fatty myelin insulation. And without that myelin, the electrical signal just leaks out and slows down to a crawl.
So seeing how these two specific failure modes play out in real-world patients clarifies exactly why neuropathy is a syndrome with vastly different faces. Like, I was reading the case notes on diabetic peripheral neuropathy, which is the most common cause globally.
Yeah, by far.
And this is the textbook example of that slow, dying back axonal degeneration, right?
It is. Chronic high blood sugar creates toxic byproducts that clog and destroy the tiny capillaries feeding the nerves. So without blood flow, those meter-long axons literally suffocate.
That's terrifying. But a massive 1993 study, the Diabetes Control and Complications Trial, or DCCT, proved a crucial point about this mechanism. They took patients with type 1 diabetes and placed them on intensive, highly monitored blood sugar control regimens and compared them to standard care.
And the results were undeniable. Intensive control reduced the risk of developing clinical neuropathy by roughly 60%.
60%.
Yeah, it proved that this nerve starvation is dose-dependent and highly preventable. Yet, because, systemic healthcare access is so uneven, it remains the leading cause of non-traumatic lower limb amputation worldwide.
Because when the large sensory fibers die, patients lose protective sensation. So a small blister from a tight shoe goes completely unnoticed until a massive bone infection sets in.
Exactly. It's a tragic cascade.
Now, contrast that slow metabolic starvation with Guillain-Barré syndrome, or GBS. The history here is just wild.
Oh, it really is.
During World War I, French doctors Guillain, Barré, and Stroll were in the medical tents seeing soldiers develop a terrifying rapid paralysis. It started in their legs and swept upward over a matter of days.
At the time, the immediate fear was polio. Naturally.
Yeah.
But they performed spinal taps and found a bizarre signature in the cerebrospinal fluid.
Right, a massive spike in protein, but a completely normal white blood cell count. So the soldiers' bodies weren't fighting off an active virus in the spine.
No, their own immune systems were eating the insulation off their peripheral nerves.
Wow.
Yeah, Guillain-Barré is the classic acute demyelinating neuropathy. It's frequently triggered by a preceding infection, often about a food poisoning, from a bacterium called Campylobacter jejuni.
Okay.
The bacterium has surface proteins that happen to look identical to the proteins on human myelin. Yeah. Through a process called molecular mimicry, the immune system creates antibodies to fight the stomach bug. But those antibodies cross-react and launch a massive friendly fire assault on the peripheral nerves.
Which explains why standard treatments for inflammation, like steroids, are completely useless for GBS.
Exactly. Steroids just broadly dampen inflammation, but they don't remove the specific circulating antibodies that are actively chewing through the myelin.
So what do they do?
To stop GBS, doctors have to use plasma exchange, literally filtering the patient's blood to wash the attacking antibodies out, or intravenous immunoglobulin, which neutralizes them. Because if they don't act fast, the demyelination ascends to the diaphragm, paralyzing the very muscles required to breathe.
That is so scary. And if Guillain-Barré is the terrifying sudden strike, there is a slow burn version that neurologists call CIDP, right? Chronic inflammatory demyelinating polyneuropathy,
Yes, CIDP.
where the immune system slowly strips the myelin over months or years, leading to progressive weakness rather than an overnight crisis.
Right, both are immune-mediated. But if we look at an infectious cause of nerve destruction, we have to look at Mycobacterium leprae.
The bacteria that causes leprosy.
Yes, and it is still the world's leading infectious cause of peripheral neuropathy.
Here's where it gets really interesting, though, because this bacterium is absolutely fascinating. It's an obligate intracellular parasite that specifically targets and hides inside the Schwann cells, the very cells that make the myelin insulation.
Right.
But it has a bizarre vulnerability, doesn't it? It is temperature dependent.
It is. It cannot survive at normal human core body temperature.
Wow.
So it selectively migrates to the coolest tissues in the body: the fingers, the toes, the ears, and the tip of the nose. It aggressively destroys the nerve endings in those cold zones, while completely sparing warmer areas like the armpits, the groin, or the scalp.
Historically, people associated leprosy with spontaneous tissue decay and horrific skin lesions. But the bacteria aren't actually dissolving the limbs. The physical disfigurement happens purely because the bacteria destroy the A delta and C fibers, which erases the patient's ability to feel pain.
Yes.
So they repeatedly burn their hands on cooking fires or step on glass, and their repeated unfelt trauma eventually destroys the tissue.
It really highlights how vital pain is to human survival. I mean, without those alarm signals, we inadvertently destroy our own bodies.
Yeah. And in diseases like severe diabetes, GBS, or leprosy, the damage is catastrophic and visibly obvious. But this brings us to one of the most consequential quiet revolutions in modern neurology. Because for decades, a massive population of patients were in sheer agony, complaining of burning feet and electric shocks, yet the absolute gold standard medical tests showed absolutely nothing was wrong.
This is such an important part of the history. Throughout the 20th century, if a doctor suspected nerve damage, they ordered a nerve conduction study, or NCS, alongside an electromyogram, an EMG.
The standard test.
Right. These machines measure the speed and amplitude of electrical signals traveling down a nerve. If the signal is slow, you have demyelination. If the amplitude is low, axons are dying.
But the machinery had a fatal structural flaw.
Those electrodes can only detect electrical impulses moving through the large, thickly myelinated A-beta fibers. The machines are physically incapable of picking up the slow, minute electrical currents traveling through the tiny, unmyelinated C fibers.
Think about the sheer psychological toll of this. I mean, for nearly a century, millions of chronic pain patients sat in neurology clinics with feet that felt like they were on fire. The doctor runs the gold standard electrical test, the results come back perfectly normal, and the patient is told, your nerves are structurally intact. The pain must be psychosomatic.
It's heartbreaking.
They assumed the pain was entirely in the patient's heads, simply because the medical magnifying glass wasn't powerful enough to see the broken wire.
Exactly. And this dogma didn't shatter until the late 1990s and early 2000s, with the widespread adoption of the skin punch biopsy.
So instead of trying to measure electrical speed, doctors finally decided to just look at the physical wiring.
Yep. They take a 3-millimeter punch of skin from the patient's ankle or thigh, stain it with specific antibodies, and put it under a microscope to calculate the intraepidermal nerve fiber density, or IENFD.
Okay.
For the first time in history, neurologists could literally see that the raw C-fiber endings in the epidermis had vanished. It unequivocally proved the existence of small fiber neuropathy.
The validation for those patients must have been overwhelming. And this discovery triggered the biggest live debate in the field today. How much of the population's idiopathic pain with no known medical cause is actually undetected small fiber neuropathy?
This raises an important question, doesn't it? Studies are increasingly showing that conditions previously labeled as fibromyalgia or nonspecific chronic pain syndromes actually feature measurable loss of small nerve fibers. We are literally recategorizing psychological diagnoses into structural neurological ones.
This history is just a sobering reminder of how heavily we rely on the specific tools we invent. But diagnosing nerve damage isn't the only area fraught with blind spots. Historically, causing it has been full of terrible surprises, too.
Oh, absolutely.
Like when we look at medications and supplements, the mechanisms of toxicity can be incredibly counterintuitive. Take vitamin D6, for example.
Right, pyridoxine. It's a biological catalyst required for neurotransmitter synthesis. And neurologists have long known that a severe deficiency in vitamin B6 causes the axons to starve and undergo that dying back degeneration we talked about.
But culturally, we code vitamins as purely protective. The assumption is always that if a little is good, a massive dose must be better.
Which is so dangerous.
Yeah.
A landmark 1983 study in the New England Journal of Medicine documented something shocking.
Oh.
Massive megadoses of B6 supplements also cause severe sensory neuropathy.
Wait, really? The exact same damage?
Yes. The transport proteins in the cell become so overwhelmed by the sheer volume of the vitamin that the metabolic machinery just jams. It creates a U-shaped risk curve. Too little destroys the nerve, and too much destroys the nerve.
That's incredible. Another haunting example of this is thalidomide. We all know the tragic history from the late 1950s. The drug was marketed as a safe sedative for pregnant women experiencing morning sickness, and it led to a global disaster of horrific birth defects.
Which permanently altered how regulatory agencies like the FDA approve drugs.
Right. But what often gets lost in the historical narrative is that adult peripheral neuropathy was an early, glaring red flag. Long before the teratogenic effects on fetuses were fully understood, adult patients taking thalidomide for insomnia were developing painful, irreversible nerve damage.
It was one of the first major clues that the drug was profoundly toxic to growing cellular structures.
And we saw another unexpected trigger during the 1976 swine flu vaccine campaign in the U.S. The government launched a massive, accelerated immunization effort. And within months, epidemiologists spotted a terrifying statistical anomaly: a sharply elevated rate of Guillain-Barré syndrome among the vaccinated population.
Because the vaccine antigens were triggering that same molecular mimicry we see with stomach bacteria.
Right.
The government halted the entire vaccination program. And that singular event fundamentally re-architected how global health agencies monitor vaccine safety. Intensive surveillance for Guillain-Barré remains a non-negotiable standard for every new mass immunization program deployed today.
Now, when patients try to navigate this massive web of causes, from vitamins to vaccines to diabetes, they are usually handed a medical chart filled with a confusing alphabet soup of terminology.
Oh, it's very confusing for patients.
So let's do a quick lightning round here. For instance, a doctor might tell a patient they don't have polyneuropathy, but rather mononeuritis multiplex.
Okay, so it all comes down to the pattern of the damage. Polyneuropathy is symmetric. If you have high blood sugar, it bathes all your nerves equally, so both your left and right feet go numb at the exact same time.
Makes sense.
Mononeuritis multiplex is patchy and asymmetric. Your left wrist drops, and then a month later, your right foot goes numb. That random scattershot damage is often caused by vasculitis, where individual blood vessels become inflamed and choke off isolated nerves in unpredictable locations.
And a single compressed nerve, like carpal tunnel syndrome, is a mononeuropathy.
Yes.
But what happens when the damage mimics a peripheral issue, but the source is actually much higher up the chain?
This is a frequent diagnostic trap. A patient has a numb leg, and they assume they have peripheral neuropathy. But a spinal MRI reveals radiculopathy, meaning a bulging disc in the lower back is crushing the nerve root right where it exits the spinal column. Or worse, myelopathy, which is physical damage or compression of the spinal cord itself. The numbness feels identical to the patient, but the anatomical location and the required surgical treatments are completely different.
And we also have to touch on the genetic factors, like Charcot-Marie-Tooth disease, named after the physicians who described it in 1886. That remains the most common inherited neuropathy.
Right. Patients inherit mutated genes that specifically code for either the myelin insulation or the axonal structure. It's a slowly progressive disease that causes the muscles in the lower legs to waste away over decades, altering the architecture of the feet and the way the patient walks.
So we have metabolic starvation, autoimmune attacks, toxic vitamins, and genetic mutations. Which brings us to the misconceptions patients hold when they actually receive this diagnosis. The biggest myth, that neuropathy simply means your feet go numb.
Oh, absolutely not.
Yeah.
As we discussed with the C fibers, small fiber damage creates an agonizing, hyperexcitable pain state. But patients also fail to connect the dots on autonomic damage.
Right.
If the unmyelinated autonomic fibers fail, a patient might experience massive drops in blood pressure when they stand up, leading to dizzy spells. Their stomach might paralyze, causing unpredictable digestion. Because there's no tingling or pain involved, they rarely associate these systemic failures with nerve damage.
So what does this all mean? The central question every patient asks when confronted with this sprawling syndrome is this a one-way street? Once the axon dies or the myelin is stripped, are these wires dead forever?
The answer contains the most biologically hopeful truth of this entire deep dive. If a nerve dies in the central nervous system, the brain or the spinal cord, it's generally gone forever. The central system severely limits regeneration to prevent miswiring.
Okay.
But peripheral nerves retain a remarkable inherent capacity to heal. A damaged peripheral axon can physically regrow at a rate of roughly 1 millimeter per day.
1 millimeter a day is agonizingly slow, but it means regeneration is biologically possible.
It is entirely possible, but there is a rigid condition. You must remove the underlying trigger. If the neuropathy is caused by a B6 toxicity or alcohol abuse or uncontrolled blood sugar, the nerve will continue to die.
Right.
But if you stop the toxin exposure or aggressively stabilize the glucose levels, the axon cone at the tip of the nerve will start inching its way back down the limb. The recovery is rarely perfect, but meaningful clinical improvement is a reality for many patients.
Understanding this capability for regeneration is exactly why identifying the root cause is so critical. And the stakes for getting this right have really never been higher because the modern triggers are compounding. Global diabetes rates are soaring, meaning the sheer volume of metabolic nerve starvation is unprecedented.
And ironically, our greatest medical triumphs are contributing to the burden too.
How so?
Modern oncology has vastly improved cancer survival rates, but many foundational chemotherapy drugs are highly neurotoxic. We now have a massive growing population of cancer survivors who beat their disease but are left grappling with severe, chronic, chemotherapy-induced neuropathy.
And this chronic nerve pain feeds directly into other massive public health crises.
Yes, neuropathic pain is deeply intertwined with the opioid epidemic. Decades ago, doctors realized traditional painkillers were largely ineffective for nerve pain. So they pivoted to drugs originally designed for epilepsy, like gabapentin and pregabalin, which calm hyperactive nerves.
Right.
They became first-line treatments because doctors desperately wanted opioid-sparing alternatives. But today, those very drugs are flooding the market and facing intense scrutiny for their own potential for misuse and dependency.
And right on the cutting edge of modern research, we're seeing the emergence of long COVID.
It's one of the most active areas of current neurological investigation. A significant cohort of long COVID patients presenting with profound fatigue, heart rate spikes, and mysterious body pain are now testing positive on skin punch biopsies for small fiber neuropathy.
Wow.
Yeah. A viral trigger is causing systemic, autonomic, and small sensory nerve damage. So we are applying diagnostic concepts pioneered in the 1990s to decode the most pressing public health puzzle of the 2020s.
It is a phenomenal example of why medicine is never static. What was once dismissed as all in the head is now visible under a microscope. We've traced the incredible journey of these fragile biological wires today, from Charcot mapping symptoms in a Paris asylum, to the meter-long microscopic supply chains of our axons, to the devastating molecular mimicry of Guillain-Barré. We really want to thank you for coming along on this deep dive into the resilient but deeply vulnerable internal wiring of the human body.
It's been a great journey.
But before we go, consider the trajectory of what we've learned. We discovered that roughly a third of neuropathy cases today are labeled idiopathic, meaning modern medical science has absolutely no idea what is attacking the nerves. We also learned that for nearly a century, we told people in agonizing pain that their suffering was purely psychological, simply because we hadn't yet invented the skin punch biopsy to see the tiny C fibers misfiring. So as you go about your day, let this question sit with you. What invisible, entirely real physical damage is happening inside our bodies right now that we simply haven't invented the right magnifying glass to see yet? What will the skin biopsy of the 2030s finally reveal about the mysterious pain people are suffering from today?